MPNs and quality of life. And these are just some images from my center and our teams in the Carolinas in the U.S. So first, let's talk a bit about symptoms versus the concept of quality of life. So as we think about quality of life is a broad concept. Where we are versus where we think that we should be. And many things can contribute to quality of life, such as friends, family, being in Barcelona on a beautiful spring day. There are things that can ruin our quality of life that are not related to our health. So quality of life is a broad concept. And again, we can have stressors that can come from any number of spots. Now, health-related quality of life includes many things, of which symptoms are one. Now, frequently, symptoms and quality of life are used interchangeably. And I think that this is incorrect. Symptoms can be a contributor to quality of life or decrease quality of life, but there are many other aspects of having a disease that can contribute to a lower quality of life. You can have symptoms, we improve them with medicines, that's good. But if you have side effects from that medicine, it may negate that benefit that you had. Or if that medication creates tremendous financial stress, or if receiving that medication really interferes with your normal lifestyle. You have to go in 3 times a week to the doctor to get this medication. That would be a big negative in terms of quality of life. So quality of life includes many things. And as we think about health-related quality of life, we realize it's a bit of all of these things. It's symptoms, it's medication side effects, it can be sometimes prior complications. If you had a blood clot in your leg and your leg always hurts and swells, that can be a negative in terms of your quality of life. The other stressors of having a disease. And having an uncommon disease is its own stressor. If I tell someone tomorrow that they have breast cancer, they have a certain experience with that, likely, from friends, from maybe their mother or coworkers. And a whole wave of emotion comes with that. When you're told that you have a disease that you likely did not hear about until you had it, there's tremendous uncertainty. And there's also isolation. Because if you go to work and you tell someone that you have polycythemia vera, people do not know what that is. And everyone either thinks, one, that you're going to die tomorrow, or two, that it's not that big a deal. And two, they also judge how you're doing by how you look. And that is not a very helpful construct for MPNs. It is true that if someone has advanced esophageal cancer, they look very sick. In a disease like this, you might feel very poorly, but you don't necessarily have external signs that really validate that. So what happens is people don't want to talk about it. I don't want to talk about my MPN because I don't want to go through that. I don't want to explain it. I don't want to explain all the stuff and the medicine that I'm on. I don't even want to go there. Now, finances can be a negative in terms of the quality of life. I lead a large team in the U.S., and we put in place something to really try to help navigate the financial challenges patients can face. So we have a financial toxicity tumor board where we have a specialized team that help patients try to navigate the difficulties that they face. So that there in yellow, that is the First Lady of the United States, Dr. Jill Biden, who was very interested in our program and came to visit our center. And next to her is the director of the National Cancer Institute. So some of our efforts in both financial toxicity as well as in patient navigation. So we have an extensive team that really help patients try to overcome their difficulties, and these are two models that are being replicated in various centers across the country. So at our center last year, we saw 40,000 new patients. Every patient receives a series of questionnaires before they come in to identify unmet needs, stressors, or pain, and then are really connected with resources even in advance of coming in to try to get them to the right teams to help to solve those things even before they've seen a physician in case there's an unmet need. So we have both kind of navigation services, and again, every disease is different and complicated. If you have myelofibrosis, if you have myeloma, if you have ovarian cancer, these are all very different diseases, different needs, different ages. We have navigators that really focus on younger individuals. You know, I'm a parent and I have a cancer or a blood disease. I'm a teenager. I need to have fertility preservation, you know, on and on. And financial challenges are significant. And going around the world, I realize that it is very different in every country, but there's always some issue. You know, in the US, we have a crazy healthcare system. How healthcare is financed in the US it's a mess. You know, in Europe, clearly you face a different challenge. Either medicine is approved, but then it's a narrower list, or you have to jump through all sorts of hoops, as we say in the US, to try to get this medicine. Now, as we think about symptoms particularly, symptoms tell us something about the MPN, how it is behaving, whether it is changing, and a bit whether things are in balance. I share with many patients, my goal when I'm treating a patient with an MPN is to really try to have their disease be as invisible in their life as possible, realizing that sometimes that is more achievable than others. Now, the symptoms can include many different things. And why we know this list of symptoms is that you told us. It was Joyce Niblack, who was a very impactful MPN patient, such as Peter, but many years ago, who really drove a lot of this work. We started this work because Joyce came to us and said, we're having these symptoms. You know we're having these symptoms because patients are telling you. Yet we see doctors who rarely see MPNs and they're not listening to us. Help us define what these symptoms are. Help us tell this story. So we started with online questionnaires using patient groups in the US and Canada, some European patients, but an earlier form of what MPN World is striving to do. And it sounds like that's a very robust system. So that sounds, very, very exciting. Now the symptoms, as I interact with physicians, I tell them that symptoms are a part of thinking about the individual. It's not only about symptoms, but on the flip side, you can't ignore symptoms. Symptoms are important. Are they there? Which symptoms? How bad are they? Do they respond to medicine? Prior blood clots, risk of blood clots, where the blood counts are at, enlargement of the spleen. And then also, very importantly, the age, the fitness, the medications an individual is on, their other medical history, all of that is very relevant. You could take the same MPN and have it in someone who's 27 or 77, and very obviously these are going to be very different situations. We have to consider all of these things. Now, what if symptoms told us about the biology of the disease? So the symptoms are not just out of the blue, and you did not make them up. They are a side effect of the disease. Now, there can be other contributors. When we first tried to publish our findings, we had data from 1,500 patients, and it submitted to the journal Blood. This was back in 2006. And the reviewer one said, well, I have seen 2 patients with MPNs. they did not complain to me about symptoms. I think these other 1,500 patients are lying. And they soundly rejected the paper, which we then published in Cancer. So one, it was a ridiculous statement by the reviewer. And two, showed, again, that you really need to look at the whole to really understand. People had claimed, well, symptoms are just because people are stressed or worried. And what we've learned is that there's, as I had mentioned earlier with Peter, that there's some contribution of both. Particularly as it relates to fatigue, probably can have a contribution of both, but there can be other contributors. Now we've learned that the symptoms are potentially associated with inflammation, and Martin had mentioned that earlier in answering one of the questions. These squares here in green and red, this was in myelofibrosis, but in red is where there is inflammation, and green is where there is not inflammation for individual patients. And it shows you how prevalent that inflammation was. And inflammation can make us feel worse in a whole range of different ways. Now we've learned over time, and this doesn't project well in this room, but that the individual symptoms can be tied to elevations in proteins that we call cytokines. These are proteins in the blood that can help to be drivers of inflammation. And different cytokines can be associated with different aspects of the disease. Risk of blood clots, enlargement of the spleen, itching, fever, weight loss, or other difficulties, problems with blood flow leading to severe headaches, migraines, visual changes with severe headaches. So that the symptoms, the cytokines, inflammation, all have a relationship with one another. We have worked, and a lot of this work also done by my colleague, Dr. Robin Scherber, trying to tie how individual symptoms are tied to different aspects of biology. And in many ways, the symptoms are another test telling us how the disease is behaving. What I share with physicians is when you see a patient with an MPN, be mindful of one, what they're telling you in terms of their symptoms, what they're telling you in terms of how well the medicine agrees with them. Yes, the blood counts, but not only the blood counts. There are physicians that I know who look at the blood sheet and say, I see you're doing fine. We'll see you again in 6 months. They've only looked at the sheet of the blood counts. The blood counts are one piece, but they do not tell the whole story. And then the physical exam. Is the spleen enlarged? Have people lost weight? Their color? After many years, I could go through a waiting room and I can tell a bit of who has what condition before I've even seen them. Abdominal symptoms similarly have a whole range of contributors. Now we have data now in thousands of patients. Data, almost equivalent data in 5,000 patients with MPNs across many different countries. And we've learned several things. Let me move it up here. Yeah, back up. One, we've learned that the ranking of the symptoms is the same across most countries in the world. We have data from Africa, from Australia, clearly from Spain, Portugal, you name it. We can compare different dialects in terms of, Latin America versus Spain. We can do all of this. And there's a cultural piece that relates to the severity of symptoms, but not the ranking. So the ranking is very consistent across the globe. The closer one gets to the Mediterranean, the higher the severity, but the ranking is still the same. So there are cultural contributions as to how people, what severe a score people put in, but the ranking is the same. Now, when we use these scores, the comparison between cultures does not matter at all, because really, we compare everyone really just against themselves. You know, if my symptom is a 4 and Marina's is an 8, what matters is if we're better, does that 4 go to a 2 and her 8 go to a 4? Because it still may be objectively the same. So that's why we never compare between patients. We only compare change relative to the baseline. Because every individual is different. You know, some people tolerate pain, some not. When my wife delivered our children, I had an epidural because it looked so painful that I was feeling it. So even I needed the epidural. My wife was a Swede. She's like, I'm fine. I'm fine. Now, the symptoms we've also found have information related to severity of disease. Not all the symptoms are the same. There are certain symptoms that we associate clearly with disease progression. So weight loss. So one, in the US, no one loses weight without trying. Most of us try and still don't lose weight. When people are losing weight without trying, barring other illnesses, that in particular in MF is a sign of disease progression. And there's others, documented fever, bone pain. Those really concern me. Fatigue is so universal, difficult to spread out. Itching, more common in PV. Symptoms such as difficulties with concentration, headaches, migraines tend to really be associated with inadequate control in the counts. So there's differences between the symptoms, and changes in the symptoms do tell their own story. And they can be predictive of survival. Now, over time, we have seen that with medications, particularly with JAK inhibitors, but with others, some impact of decreasing inflammation and improving symptoms may also be associated with helping to slow the progression of the disease down. You know, when we try to study the issue of why do MPN patients progress, we don't fully understand every aspect of this. But one aspect we believe that is likely is that in the bone marrow there can be this uncontrolled inflammation, and by quelling that inflammation, we may decrease that risk. That may be one of the reasons that the JAK inhibitors overall as a class have been helpful in trying to delay disease progression in MF. They don't stop it overall, and in some people it's been much more successful than others, but that may be a factor. Certainly Hans Hasselbach has speculated that, again, with interferon, when effective, that may be helpful in terms of the bone marrow for these patients. Now, measuring symptoms is important. I had mentioned that we have data now with standardized questionnaires, and some of you have probably taken variants of this in many patients, and evolved the scores to first start with myelofibrosis, and now included vascular and mood symptoms, and now are helpful in ET and PV. And in many ways, it's the symptom data that has actually been the most validated data that we have in terms of MPNs, in terms of how do we correlate kind of clinical benefit versus a change in terms of symptoms. There's other markers that we have very good evidence around, such as a hematocrit of 45%, but there's other things that we have much less solid information. How much does the spleen have to shrink to be meaningfully decreased? What is the exact white blood cell count that we need to try to target? What is the exact platelet count that we need to achieve? Many of those things we have consensus, but we don't really have much evidence of their correlation. We now have, and I have to update this because I think we're up to about 40 different languages around the world. And again, a core item are just 10 items, but we have a longer kind of 27 item form And again, just showing English or Arabic, although Arabic, you go from right to left when you fill it out. Now with these, what's frequently a surprise for physicians is how many symptoms patients with ET also have. So first, physicians, one, weren't sure that MPN patients actually had symptoms. Two, then they believed that MF patients had symptoms, but were still more skeptical about ET and PV. What we've learned over time is that clearly MF as a group are the most symptomatic, then PV, and then ET. But within that, there are patients with ET that have more symptoms than other patients with MF. So let me share just some of the lessons that we've learned. First, the symptoms are real and they are more than the general population. So again, another reviewer along the way said, well, you're telling me these patients are tired. I'm tired. My kids, I have to drive them everywhere. I have to work long hours. We're all tired. Just suck it up, as they say in the US. So we did a study with our colleagues in Ireland where they took age-matched controls of just people in the general public, and were able to show by symptom there is no question that MPN patients have more symptoms than the general public as a group. There are MPN patients that have no symptoms. This is a minority, but this absolutely exists. Now, we looked at symptoms by disease risk. And we learned that the symptoms do not necessarily associate with just the risk. Risk in ET and PV is associated with what is the risk of having a blood clot. The risk of having a blood clot and the symptoms that you have are not necessarily exactly the same thing. Likewise, in myelofibrosis, where risk has been studied around the risk of how likely is the disease to become life-threatening, there's a weak correlation, but it's not necessarily the exact same thing. You can be a young patient with MF with many years of life, but still feel poorly. And that's why, as we created the US guidelines for treating MPNs, said that you have to consider both the risk and what the patient is actually feeling, because they might be different. Now, it's interesting, when we did a study asking both patients and physicians what were the goals of treating the MPN. And we asked, this was for ET, whether we were trying to prevent blood clots, improve quality of life, improve symptoms. And there is a discrepancy between physicians and patients. Physicians have typically prioritized, again, this is the way we're taught, to treat what we are able to treat, which is to decrease the risk of blood clots. Patients, they really wanted to, the line in blue versus that line in green, they want to slow the progression of their condition, which I agree with 100%. Physicians, we have minimized this because we weren't sure that we had something to slow the progression down. But patients telling us we want to slow the progression of our disease down. It doesn't necessarily mean that they want to have a blood clot. It doesn't mean that they want to have a worse quality of life, but they want to slow the disease down. The same was true with polycythemia vera, and this was in 400 patients. And here was the huge difference as related to physicians and patients for myelofibrosis. This is now post-approval of ruxolitinib. Physicians said, I really want to improve the symptoms of my patients with myelofibrosis, which I found ironic after having a hard time publishing the initial papers saying that patients had symptoms. But myelofibrosis patients said, please help us slow down the progression of our disease. My takeaway from all of this is not that patients wanted to feel worse, but they really want to slow down the progression of the disease. That was a universal theme, and that really pushes us forward that our medicines are just not good enough. They have improved, but they are just not good enough yet. And there was also a European version of this study that really found the same outcomes. Now, other things we looked at, what is the threshold for symptomatic enough to start on a treatment? Again, an individualized discussion. But overall, we found any individual item that was roughly 5 out of 10 was enough people say, get me on something. Or 20 out of 100 for the 10-item scale. We looked at symptom thresholds for people who are on hydroxyurea who feel that they're not feeling well enough when asking them about their therapy. This was a study that I had mentioned that we published in Cancer. This was called the Fatigue Project, and this was in 2014. And this is where we found that overall patients with MPNs had higher rates of anxiety, stress, and grief. All treatable, but clearly identifying that and dealing with that with physicians is kind of the first key step. So again, when I have patients that really have, everything else is kind of responded, and fatigue or other things are really lacking. Again, I made the joke about losing weight before, but sometimes, again, that can be a sign of, I just don't want to go out, I'm not hungry, I don't want to eat. All can be signs of depression. And again, we were able to do very intensive modeling around this. We saw in the US that patients were leaving work because of their MPN. And again, medical disability looks different in every country, but that people were either retiring earlier or cutting back on their number of hours. I see many physicians and hematologists who have MPNs who then come to see me in the US. And they'll say, well, I never really thought that this disease affected people very much until I had it. And then they're like, wow, I really can't tell when my platelet count is too high and I need to adjust my medicine. Boy, I know when I need another phlebotomy. I think I always undervalued what my patients were telling me, but now I have the disease, and yeah, I need a phlebotomy. I bet I'm 49% today. So physicians really validating again that what you're feeling is very real, and also that boy, I used to work 40 hours in my practice, and I just don't have the energy to do that. I can't concentrate that. I now work 4 half days, and that's okay for me. So everyone is different, but sometimes, that adjustment, whatever that is, sometimes is very helpful as well. Because again, one of the strategies, of which there's many for dealing with fatigue, but sometimes is just the ability to say, this is what I can do, and to allow yourself that freedom. We learned that symptoms cluster. They're not necessarily all independent, and that there's clusters of symptoms, again, that cluster together that tell us different things about the biology of the disease. Here were different, this was the heterogeneity analysis. So we broke down symptoms by quartiles in terms of the intensity of symptoms. So ET, PV, and MF, different clusters, but you see on the right, so each line represents one patient from top to bottom. Each are symptoms. So there's a tremendous amount of data in a small, compact space, with red being all the way at 10 and blue being 0, and the colors kind of in between being them. But as you see more red as you go, you see groups that have more symptoms. And you see, again, that there are groups with ET that have more symptoms than that group on the left with MF. So that although we have the 3 diseases, there clearly can be overlap in terms of the symptoms that patients face. We've learned that there is an impact of duration of disease on symptoms as overall a learning piece. We've learned that there's a difference between men and women as it relates to symptoms, with many contributors, including the reproductive cycle, the impact of iron deficiency in menstruation, hormonal changes, how the curve with men and androgens goes is totally different than kind of the estrogen. So all of these things are probably a factor. And then there are probably other cultural factors that really contribute as well. But overall, we saw higher levels of fatigue, more abdominal symptoms, more microvascular symptoms, and overall higher symptom scores. We saw that insomnia is a big issue, big compared to the general population, and somewhat logical. Take someone, I can feel my spleen, I'm having itching, I'm having night sweats. It is not illogical to realize that there's an impact on sleep. It's very hard to feel well if you are not sleeping well. So right now, I'm doing a trial that's funded by the National Cancer Institute. We're doing this across 400 patients with different hematologic malignancies, but looking at meditation. It's a meditation app. We're using the meditation app. There was an MPN study that started this, so some of you may have participated in that, but then looking at sleep using the Aura ring that kind of tracks sleep, and then inflammation. And then, because many of these interventions, yoga, exercise, meditation, almost all of them have as a final common pathway an impact on sleep. You sleep better, your body is able to restore itself. If you don't have that cycle, it has a real negative impact. Sexuality. Again, rare the MPN talk you hear that talks about sex. This one does. So in many ways, so I mentioned that fatigue was the #1 complaint. This was #2. And that was around the world. And again, something people don't bring up, but logical in many ways. And in many ways, I think it is a distillation of how you feel. Because whatever someone's sexuality is for them and their importance that they place on that, and that is different in everyone. If you're not feeling well, it's usually the first thing that goes. I feel itchy, I'm having night sweats, the last thing I want to do is be intimate. On the flip side, what we've seen, particularly the early days with the first JAK inhibitor studies, if you make someone feel really much better, it's one of the first things that comes back. So this, in many ways, boy, if I could ask one question and get an honest answer, this tells me a lot. And it's very important to individuals, regardless of age. So too frequently in our world, in medicine, we don't ask, we don't feel that we have a way to intervene, or people make assumptions that it's not important to someone because they're older or what have you. And again, very, very helpful information. We did analysis regarding, what drives quality of life? So this was done with our statistical colleagues, tremendous amount of data in here, a correlative analysis, but showing the two biggest drivers were really untreated mood disorder or undertreated symptoms were the single biggest drivers of quality of life, health-related quality of life for MPN patients. Clinical trials, I shared that there's fundamentally two things that any therapy does. It either helps people live longer, helps people live better, or both. Everything else is a surrogate. If you improve the hemoglobin, why do we care? Do you live longer? Do you live better? Maybe both. But everything else is a surrogate of one of those two findings. Symptom as a trial endpoint, again, this a bit more for physicians, but what I really try to share as we really think about evaluating new medicines is that symptoms are an important piece of that. It's not the whole piece by any means, but it's an important piece. I have spoken in front of the EMA and the FDA many, many times, and both of them really look at, what is the clinical benefit to the patient? In aggregate, what are you helping to improve? What is the toxicity or the cost? in terms of being on that medicine. The financial part usually does not factor into either group in terms of the approval of a medication. Whether a medication ends up being covered by a country or an insurance company, they pay close attention to the cost piece. But the approval piece is only really around effectiveness. And they always balance effectiveness as to what do you gain from being on the medicine, but what do you lose in terms of any potential side effect, short-term or long-term. So I'll just give an example. Whether someone has symptoms factors into our treatment guidelines in the US and various treatments around the world as well. So for myelofibrosis, for example, if someone has low-risk myelofibrosis and truly has no symptoms, this may be a group that we may still observe with the disease. They may still get interferon. But if they're symptomatic, then that really changes things. It impacts PV, it impacts ET. It's just showing, again, in various studies, we have the momelotinib that's now approved, and in part because of its impact on improving spleen symptoms and anemia. But it was improvement of symptoms that was the primary driver of its approval. This was a drug that we just saw a large study on. And again, the difference in both improvement in spleen and improvement in symptoms being looked at very carefully in terms of the benefit with the medications. So where do we go from here? One, we're clearly trying to find better pharmacologic therapies for the disease. Two, I think there's an increasing amount of effort to see, well, what else can we do to help people feel better in addition to medicines? One thing, having been involved with caring for patients for many years, I don't think that a prescription pad alone is going to fully help people feel as well as they can. Eating well, exercising, as well as other tools. We saw on that video of the patient that Peter interviewed that had a cognitive intervention, meaning she worked with her psychologist who basically gave her some of the tools of how do I give myself permission to not think about the disease. Or when I go to bed at night, I don't work myself up into a frenzy and can't sleep because I'm just worried about my disease. How do you just ignore it? These are tools that can be helpful. This was a study looking at different complementary ways that MPN patients were trying to impact their disease. So in this particular study, there were patients from 52 different countries that participated in this study. And in this group, we saw that exercise, massage, yoga, strength training, breathing exercises, and support groups all having an impact. All things that, well, what else can I do other than adjust the dose of my medications? Yeah, that can help, but it has a finite capacity to help with that. We've done studies on yoga, and that is out there. And we actually had a group that was, I think, in Bulgaria that developed an MPN-specific kind of light yoga that could be used for individuals without increasing spleen pressure. And then this isn't projecting well, but we showed this to be effective in MPN patients, now being tested in others. And then this is the ongoing study that we have, the heme study, for 400 patients with heme malignancies who are on stable doses of medications. So to conclude, MPN-related symptoms are common and they impact health-related quality of life, but they're two different things. They're a marker of the disease. They tell us about the biology of the disease. I do think as the more effective therapies that we have, the more it impacts what people are feeling. There is no question. You know, and if we have a medicine that is dramatically better, I think we will know because you will feel it. You know, and it's people adjust to symptoms so that sometimes people don't know how they have been feeling until they're on a medicine that really adequately treats their disease, and then they feel something different, particularly if they've had it for a long time. The improvement in symptoms should be part of a comprehensive approach for evaluating both where disease stands and improvements. And I think more and more, I think a toolbox of integrative approaches that can really help with additional things, you know, hopefully will help patients in addition to medications. And with that, very much want to thank really the MPN patient community. It's really because of people's willingness to contribute to these efforts that we've learned any of these things. And really grateful for all of those efforts, as well as, you know, the creation of new platforms that allow people to interact. Thank you.
Without. Do you have any possibilities to measure the inflammation of the patients?
Yes. So we clearly can now do these cytokine panels. What we still don't quite know yet is which cytokines are the most important and what is the target for what we need to do to change them. We've just had several very large studies recently complete in myelofibrosis where we're studying data in many of these to try to see which of these are the most important and then how do we really leverage that. So some of them that are in that group, for those more familiar, TGF-beta, interleukin-8 has in particular been one that can be associated with more difficult disease, TNF-alpha, amongst others. But I think over time we will learn more about kind of the inflammasome, which is kind of the aggregate of all of these different parts of inflammation, in part with some of the other pieces that we have.
Is it complicated from the laboratory side, or may one day it be a standard like the other blood tests?
I think in terms of from the lab side, it's not difficult. I think the key is first us figuring out which of the cytokines are the most important. Because part of us identifying what matters is not testing it once, but testing it in the context of serial changes in response to a benefit. So the more we see therapies that benefit, the more we're able to tell, well, boy, it was this decrease in this cytokine that mattered.